All right, let's talk about a microbe that you've probably seen in the lab, but one that might not be what you think it is anymore. Today we're diving into Schaalia odontolytica. Its recent name change is way more than just a little footnote in a textbook. It's actually impacting our diagnostic systems right now. We're going to explore what this means for your workflow, all the way from identification to treatment. Now, this entire briefing is sourced from a Gemini deep search, and you can find the complete list of sources in the linked notebook. So let's get right into it.
So here's the game plan. We're going to follow the complete journey of this organism, right? First, we'll cover its new identity, then we'll get our hands dirty with the diagnostics. After that, we'll look at the clinical picture it paints, figure out the best treatment strategies, tackle the really tricky issue of susceptibility testing, and then we'll wrap it all up with prevention.
All right, first up, the name change. You know, it might seem like just a small detail, but as we're about to see, this taxonomic shift has some pretty significant downstream effects on our day-to-day lab operations.
And this is really the core issue we need to tackle, right? This isn't just about updating our vocabulary, it's about making sure our diagnostic tools can actually keep up so that we're providing accurate and timely results to the clinicians.
So here it is, plain and simple, the old name versus the new. This change was made official back in 2018, and it was all driven by some pretty powerful genomic analysis. What it revealed was that the old Actinomyces genus was polyphyletic, which is basically a scientific way of saying it was a mixed bag of organisms that didn't really belong together. Creating the new Schaalia genus gives us a monophyletic group, which is a much more accurate, scientifically valid classification.
And here's where the rubber really meets the road for us in the lab. Our MALDI-TOUGH systems, they're amazing, but they are completely dependent on their databases. So if that database hasn't been updated to recognize Schaalia, it's going to fail. You'll get a low-confidence ID or maybe no ID at all. And just like that, your whole rapid workflow grinds to a halt. Suddenly, you're forced to fall back on slower, more expensive methods like 16S RNA sequencing, all while a clinician is waiting for that result.
Okay, so now that we understand the what, let's really focus on the how. How do we actually identify this organism when it shows up at the bench?
So under the microscope, Schaalia odontolytica gives us some really classic clues. It's a gram-positive, pleomorphic rod. You know, kind of diphtheroid. But what really makes it stand out is that thin, branching, filamentous structure. That's the feature that gives it that almost fungal-like appearance and led to the old misnomer ray fungus.
And on the culture plate, we get this really helpful visual cue. Schaalia odontolytica is a slow-growing facultative anaerobe, so you're going to need some patience. I mean, it can take up to 14 days to grow. But after that anaerobic incubation, once you expose the plate to air, you'll start to see this beautiful, distinctive dark red or brownish red pigment develop. It is a fantastic marker to watch out for.
So this all comes together in a really clear, tiered workflow. We start with the gram stain for those initial clues, followed by the anaerobic culture to hopefully see that characteristic growth, and ideally, our updated MALDI-TOUGH gives us a quick, confident ID. But for any case where there's ambiguity, 16S RNA sequencing is our definitive gold standard for confirmation.
Okay, so let's connect our lab findings back to the patient. Schaalia odontolytica is a known cause of actinomycosis, which is a disease that's just notorious for being a diagnostic camellia.
And this is really important. It's an endogenous infection. This means it comes from the patient's own flora. It's not contagious. It only becomes a problem when a mucosal barrier gets breached, allowing this otherwise harmless commensal to invade deeper tissues. The most common site by a pretty wide margin is cervicofacial, the classic lumpy jaw, making up over half of all cases. Abdominal, pelvic, and thoracic infections are the next most frequent.
So what opens the door for this bug to become a pathogen? Well, the risk factors are pretty well defined. Poor dental hygiene is, without a doubt, the #1 risk factor for that common cervicofacial form. Other major factors include things like immunosuppression, diabetes, and, for the pelvic form specifically, the long-term use of intrauterine devices, or IUDs.
This quote just gets right to the heart of the clinical challenge. Actinomycosis creates these hard, slow-growing masses that don't respect tissue boundaries. So you can imagine, a mass like that in the chest or the jaw, it immediately makes you think cancer, and that leads to misdiagnosis. Tragically, this can result in patients undergoing unnecessary, extensive surgery for what is ultimately a curable infectious disease.
So if we can avoid that misdiagnosis and get the right identification, how do we treat it? Well, the key here is a pretty unique therapeutic approach. We're talking long-term, high-dose antibiotic therapy.
If we look at the Dutch guidelines, which are a pretty good model for international practice, we see this two-pronged approach. For severe infections, you start with a 2 to 6 week course of high-dose intravenous benzyl penicillin. This then gets stepped down to oral amoxicillin for a really long time, anywhere from 3 to 12 months. And that's the key here, the duration. You need that long course to penetrate those dense fibrotic lesions.
Now for pediatric patients, the principles are very similar, just with doses adjusted for weight. The treatment duration stays very long, often with a median of about 6 months. This is largely because children who get actinomycosis have a really high rate of complicating osteomyelitis, bone infection, which requires that prolonged therapy to cure.
All right, now we get to what is maybe the most critical challenge for the modern microbiology lab. How in the world do we handle antimicrobial susceptibility testing for this organism? This data from a 2022 study by Naji and colleagues is incredibly revealing. It confirms that the organism continues to be susceptible to beta-lactams like penicillin. Look at that low MIC90 of 0.125. However, it also shows some very concerning high-level resistance to moxifloxacin and daptomycin. This finding argues really strongly against just empirically using a fluoroquinolone for these infections.
And here is the critical gap. We can generate an MIC value in the lab, no problem. But without official EUCAST clinical breakpoints, we have no standardized way to interpret it. And that means we can't report a simple susceptible, intermediate, or resistant result back to the clinician.
So what are we supposed to do? Well, thankfully, EUCAST gives us clear guidance for this exact situation. First, you report only the numerical MIC value. Second, and this is a big one, do not try to extrapolate breakpoints from other species. Third, and this is key, add an interpretive comment to the report explaining the situation. And finally, advise that penicillin is generally considered the treatment of choice and that susceptibility can usually be inferred.
Okay, let's wrap this up with how we can help prevent these infections, and some final thoughts on our evolving role as microbiologists.
Since this is an endogenous infection, prevention isn't about things like quarantine or contact tracing. It's all host-focused. So for the most common forms, that means excellent oral hygiene. For pelvic disease, it's about the regular changing of IUDs. And for any patient who is diagnosed, education on the absolute necessity of completing that full, long antibiotic course is critical to prevent a relapse.
You know, cases like this really highlight a fundamental shift in our profession. With taxonomy constantly evolving and challenges like missing breakpoints, our job isn't just about generating data anymore. So the real question we're facing is this: how do we effectively transition into a more consultative role to help guide clinicians through all this growing complexity?
And that wraps up our deep dive into Schaalia odontolytica. We really hope this was a useful update for your practice. If you want more microbiology briefings just like this one, please subscribe to the channel. And honestly, we'd love to hear from you. Share your own experiences with this organism down in the comments. Thanks for your time.